Can I start by also welcoming Mark Newman, who is going to be the co-host for this evening. Thanks for giving up your time, Mark.
Good evening, everyone. It's good to see so many people logging on.
So in this webinar, we're going to look at using internal fixation and primary closure or delayed primary closure for managing open fractures. And just before we start, I just want to make you aware of something that's coming up towards the end of the year. We've got AOVET's running 4 interactive webinars over 4 weeks. And this is really aimed at bridging the gap between a lot of the research that's being done that's very much clinically relevant to what we do in practice on a daily basis, but is just not being well enough connected or quick enough connected to practitioners. So the Education Commission and the Research Commission have been doing a lot of work to try and bridge this gap. And what we're looking for is to reach out to the world and try and find 20 abstracts that are really at the cutting edge of clinical, practically relevant orthopedic research. So stuff that's directly transferable to clinical practice that can inform what we do. So if any of you listening tonight are AOVET members and you have clinically relevant transferable research, then we'd love you to submit an abstract. This is an international panel that will review these, and we will then select those. And the aim really is to ultimately for you to submit a 12-minute video that showcases your work, and this will run over about an hour. And at the end of that, we'll take a subject expert from around the world who will put the context on that and formulate the discussion around this. And then, of course, it'll be open for discussion and questions with the world. So we're really very excited about this. I think it's going to be a great innovation. And if you have some research that has not been published, it can have been presented at scientific fora around the world, but providing it hasn't been published, then you can submit it for this symposium. And we have 3 seminars in small animals and 1 in equine. So we'd love you to be involved in that. The call for abstracts opens as of today, and you have just under a month to submit the abstract, and then the dates for the symposia are there. So hopefully we've encouraged you to get involved. But you can contact AOVET for that, or if you want specific information, you can contact me. My email's available at the front and the back of this webinar. The link is there on how to apply, and again, it's easy. We'd love to showcase your work to the world. Okay, so let's get back to this webinar, and the objectives of this session are really to very briefly review the classification of open fractures, and we'll use the traditional Castillo-Anderson classification. I want to look at some of the outcomes of internal fixation and primary closure and compare these with the external fixation and open wound management that still is very commonly used in small animal practice. And we'll contrast this against what's done in humans. It's all about internal fixation. We'll look at the decision making on when we should do the initial surgery. I want to particularly focus on the issue that caused a lot of confusion, which is the difference between contamination and infection. And when we first are presented with an open fracture, it's contaminated, it is not infected, and what you do makes a difference ultimately to whether it will be infected. we'll look at the really complex issue of whether there's any benefit in doing an entry or exit culture at the time of your surgery to stabilise the fracture. We'll talk briefly about rational antibiotic use, and I'll show you some case examples where in one case I've irrationally used antibiotics, and I think that we're, as a profession at the moment, still a little guilty of irrational use of antibiotics in open fractures. And we'll look at also the issue of should we be removing any of these implants that we place when we manage an open fracture. So how we're going to look at those learning objectives, firstly, we'll just briefly review classification just so we're all on the same page. And I apologise if this is old news to you. And then we'll look at what evidence we have, and I think it's really important that we base everything that we do on evidence where it's available. Unfortunately for open fractures in veterinary medicine, there's little evidence. I'll show you a case series that we're putting together where we have some evidence, none of it's conclusive. So we'll work through these one at a time, and then at the end we'll look in more detail at 5 of the case examples. So this is the traditional classification that's been used in humans since the 70s and similar time in veterinary medicine. And the original intention was that this is aimed to convey the amount of trauma energy, the amount of energy that's caused the injury, both in terms of the degree of soft tissue injury, but also in the extent of the bone damage. And if we look at the type 1 open fracture on the left, and again, any time there's a full thickness open wound adjacent to a fractured bone, then we must classify this as an open fracture, and it's certainly contraindicated to start probing these open wounds to find if they do communicate with the bone. It's essential that we classify them, if it's full thickness, as an open fracture, so a type 1 open fracture. And these are typically low energy trauma. The fracture pattern is simple, so in other words, it's not comminuted, so it's oblique or a transverse fracture. And typically the open wound has been caused by internal trauma. So this would be the fragment ends puncturing the soft tissue envelope and making a hole in the skin. If we look at the 2 and 3, these are higher energy trauma, and immediately we have a comminuted fracture pattern. So we don't have that simple non-comminuted type. And in the 2s and 3s, the soft tissue defect has been caused by external trauma rather than just the internal trauma of the bone ends coming out. Now, in type 2, there's no major defects, so there's no big flaps or soft tissue avulsions, and these are, if you like, able to be primarily closed without tension. And then if we look at the type 3, and these have been further subclassified into these 3 grades. This was a follow-up step from Castillo and Anderson, because the type 3s are quite different. For us in veterinary medicine, a type 3C injury is essentially an amputation. These are the ones where the arterial supply is destroyed, and for the vast majority, these are certainly not salvageable. So really what we're talking about in veterinary medicine is managing type 3A and type 3B. And these are very comminuted or segmental fracture patterns, and there's significant external trauma. So there's a large soft tissue deficit or a large flap that needs to be repaired. And in these cases, and 2 examples pictured here, these are certainly very salvageable, but you have to have an owner that is committed both emotionally and financially to that leg and to that animal, because there's significant expense and significant aftercare that's required in managing these. Okay, so before we go into some of the key points, I just want to show you the 5 cases that we'll look at, and I'll ask you at this point really just to think, if you were presented with these cases tomorrow, how would you manage them at the moment? And I can tell you the examples I have here is how we would manage them at Murdoch, and we would rarely use external fixation for open fractures. It would only be if there was some major type 3, usually type 3B injury that we just couldn't get a flap on, that we would do long-term open wound management, really if there's no other alternative. So in our series of 33 open fractures that were treated with internal fixation that we're just retrospectively looking at the moment, 10 type 1s, 13 type 2s, 5 3As, and these were all treated with single stage, so single surgery, debride, fix and close. And for the 3 type 3Bs, and I'll show you 2 examples of those, they were treated with either a single stage debride, fix, and by fix I mean stabilize, and flap, so using an axial pattern flap or some type of flap, or we did short-term open wound management with delayed fixation and flap. So we'll have a look at examples of each of these, but really the bottom line that I want to emphasize is that we would do everything we can not to use external fixation. We would use internal fixation as our go-to, and during the webinar we'll look at some of the reasons behind this. So the first case that we'll come back to, but I'll ask you to have a think about, is a young cat, Jellybean, who's got on the wrong side of a dog, and this dog's had a good go at Jellybean's leg, and you can see that there's a high energy crush injury here. The tibia is comminuted, and this is a type 2 open fracture, so there's no major soft tissue deficits, there's no flaps, these can all be closed, but really quite extensive crush injury. So how would you manage this fracture if you were presented with this tomorrow? Second one we'll look at is a larger dog, a middle-aged dog, kicked by a horse. This fracture is about 20 hours old at the time it presents to you, and we'll have a closer look at that wound, but there's no deficit, so the open wound on the caudal aspect of the distal tibia there can be primarily closed, but you can see that there's comminution of the fracture, so a type 2 open fracture. This is another type 2 open fracture, a very comminuted articular fracture of the proximal ulna in this beautiful little puppy, and you can see that this dog was managed at an emergency centre. It's had initial lavage and essentially some debridement, and the wounds have been temporarily closed. But this is a challenging fracture, and again, I'd ask you to think about how would you manage this fracture if you were presented with this case tomorrow. Gorgeous little dog. And now the fourth case is a type 3B open proximal tibial fracture, and you can see it's quite proximal. This dog's had a previous extracapsular repair some years ago, and there's really major soft tissue deficit. We'll have more of a look at this in detail when we come to it, but there's a whole lot of necrotic soft tissue here over the medial tibia, so quite a challenging fracture. And then the final case we'll look at is really one that I find particularly challenging. I don't think we have a good solution for these, and I'd be interested in the discussion if someone has the miracle cure for these. But these metatarsal or metacarpal injuries where it's very, very difficult to get a flap to. But how would you manage this if the owner said, well, we want to proceed, we want to stabilise this leg? So that's where we're going to in the case studies. But first, I want to really address some of these questions and see what we can learn from looking at the human literature and what I can share with you from our case series experience. So if we're presented with an open fracture, it comes in the evening or during the night. Should we be getting a team out of bed and starting to look at operating on these and looking at debridement? If we go back, this is the landmark paper from 1976 by Gastillo and Anderson, really remarkable paper at the time. And at the end of this retrospective of human cases, they came up with 5 principles for managing open fractures. And one of the principles was emergency debridement of these open fractures. Now, since then, there's been a number of human papers that have looked at the evidence behind this, what we talk about the golden period, or some people talk about the 6-hour rule. And the evidence here is very, very weak for any benefit. And in fact, the 3 papers I've listed here, they're all good papers, and they found that there's no effect on infection, regardless of the severity of the open fracture or the location of the fracture, based on time to debridement. So I think this idea of emergency debridement of these open fractures is not necessary, and our approach is very much one of expedient debridement when the animal is physiologically stable. So if the animal is stable enough to be anaesthetised during the night, for example, in the emergency centre, then initial lavage and initial debridement is worthwhile. And starting with open wound management, packing that wound, that's all worthwhile. But it's not something that we would say that this has to be done if the animal's not stable or if there's other reasons. And it would certainly be preferable to put a hold on this by lavage and bandaging and wait until you have, if you like, your best team the next day, because these are extremely challenging, and you certainly don't want to take shortcuts in managing these. So what about internal fixation versus external fixation? And what I find very interesting in teaching in various countries around the world is that still very commonly the default method of treating open fractures for veterinarians around the world still seems to be external fixation, which puzzles me, and we'll look at some of the evidence that is behind this. And it's really hard to track back where this drive in veterinary medicine has come from. So one of the rationales when people at courses say, well, I would manage this with external fixation, is when I ask them, why would you do that? Why would you treat an open fracture with an external fixator? The first answer is always, well, first of all, we have to manage it as an open wound. We can't close these wounds because they're infected. And we know that that's not right. When they first present, they're contaminated. But the second reason is that people always say, well, we can stabilise these open fractures without having any metalwork close to the contaminated or the infected area. And this is just simply not true. For 2 reasons. We know that the biomechanics of external fixators are really no different to those of a plate. In fact, the biomechanics of a locked plating system are identical to an external fixator. And the principles of biomechanics in terms of achieving stability is that you want to have end of fragment stability. So in the plate example there, and I thank Tim Pearson for this case, you can see by having screws positioned in each of the main proximal and distal fragment in a far, near, far position, that's end of fragment stability. And the same principles apply for external fixators. So if you're placing an external fixator, then biomechanics dictates that you need to place the external fixation pins closest to the fracture as adjacent as you can. And so that's one of the reasons. The second thing is that to say that putting an implant, a pin or a screw anywhere in that bone segment is outside of the contaminated area is also clearly not true. There's enough evidence about how easily contamination passes through a bone segment that that entire bone segment is contaminated. So the rationalisation for using external fixators here is really very, very poor. There's no good biomechanical basis for it, and there's similarly no good biologic basis for doing that. And then the other question is, really, can you maintain that external fixator for the expected healing time? And this comes back to biologic fracture assessment. We know that certainly the type 2 and type 3 open fractures, the biology here is generally poor. So at best, we have healing that's going to be more than 10 weeks. It's unusual for an open fracture to heal in less than that time. And so can you maintain an external fixator effectively for that length of time? Remembering, of course, that stability is one of the key factors that we need to control infection. If we're to have good blood supply, good revascularization of the fracture, and therefore good resistance to infection, we need stability. Instability multiplies infection. Stability is resistant to infection. So can you maintain an external fixator long enough for that open fracture to go to healing? And if we look at some of the evidence in terms of closed radius ulnar fractures, for example, then the mean time to removal of these open fractures, of the external fixators in these closed fractures, was overall about 13 weeks. And for comminuted fractures, and remember that type 2 and type 3 open fractures are comminuted, the mean time to removal was 15 weeks. And certainly I could not reliably keep an external fixator, a well-applied external fixator, without some issues, without some need for revision, reliably for that length of time. If they healed more quickly, great. But and these again are in closed fractures that are not as biomechanically challenging. So I think one of the key points about external fixators is, can they last the distance? And I would put to you that they probably don't. The other reason that people give for using external fixators is because that's what they were taught. That's what we have to do. And the only way I can really rationalise this is to go back to that original article where in 1976 this landmark paper initially recommended strongly against internal fixation. And I think that that's where a lot of our drive towards external fixators came from. But interestingly, 4 years later, the same authors completely changed their recommendation. And that's quite astounding, I think. If you think about how long it takes to write up a paper and get it published, the only way I can understand this is that as soon as they published this recommendation in 1976, the human orthopedic world gave them such strong feedback on this that almost immediately they've written a revision. So 4 years later, they published a follow-up paper where they recommended the use of internal fixation in all types of open fractures, including the threes, provided, and this is very important, provided that primary closure is possible. And that's really quite a remarkable turnaround in the space of 4 years. But I think that perhaps veterinary medicine somehow got stuck in that period in the 70s. What is there in terms of recent veterinary publications on managing open fractures? Well, there's very little actually, and Malcolm Ness has written a nice paper in JSAP in 2006, where he didn't specifically look at managing open fractures, but he looked at managing unstable open or infected fractures using open wound management and external fixation. And here's a case example of a dog 12 days after the application of the external fixator. And if you look at the clinical significance conclusion, they found that this was stated to be an effective technique, and that the external fixators were usually effective at maintaining stability throughout what they class as an inevitably extended fracture healing period. So that's interesting, and that sounds quite good. But if you tease into this paper a little bit more, there were 6 open fractures that they presented. 2 of these 6 required revision with a bone plate, so they were classed as delayed or non-unions and had to be revised with a plate. And in half of the cases, there was premature loosening of the external fixation pins. And I suppose it depends on the interpretation of premature loosening. Is this a non-premature loosening? It's just happened, the fracture was taking too long to heal as expected, or was it truly premature loosening? And the open wound management in these 6 cases was done for between 8 and 16 weeks. And I have to say, one of the things I like about orthopedics is that I'm not blighted with dozens of revisits of the same case. And the idea of doing open wound management on an animal for 8 to 16 weeks, I think it's the owners will become pretty sick of it very quickly. The animal becomes sick of it, and certainly the hospital staff do. So certainly looking back to last century when we did manage cases like this, these were really no one liked these cases. They were really a lose-lose for everyone. So I don't think there's good evidence to support the use of external fixators. And in this session, I'm not going to go through and present in detail the case series that we have here, but all of the cases went on to union. There was one case I'll show you where it had healed and we had to explant, but certainly much better outcomes. And for those of you that are routinely managing open fractures with internal fixation and primary or delayed primary closure, I think you would agree. So in terms of open wound management being recommended as one of the original principles, it never was one of the 5 original principles of Castillo and Anderson. They recommended primary closure of the types 1 and 2 and delayed primary closure of the 3. So never was open wound management one of those principles. When we look at evidence from the human open fracture situation, we know that the main cause of infection in open fractures in people is hospital-based infection. Just over 90% of them are nosocomial infection. And while we don't have good figures on this in veterinary hospitals, there's no really good reason why it would be any different to that. There's several human studies that showed significantly better outcomes with primary closure or delayed primary closure within 7 days, as opposed to open wound management. They found, not surprisingly, reduced patient morbidity by early primary closure. They found significantly reduced infection rates. And I think what's quite important for humans as well as our veterinary patients is significantly reduced cost. So the hospital stays are shortened if we can avoid prolonged open wound management. And these, I think, are really relevant considerations for us. So if we have a chance, and I'll show you this case, we would have our soft tissue surgeons to try and, wherever possible, in a severe 3B, try and provide a flap. This is a case of a pouch flap. These are very problematic. This will be the last case I show you, but these are not the be all and end all, but we don't really have a better way of getting a blood supply to these at the moment. So one of the key points I want to make in this webinar is that managing open fractures is all about the soft tissue. Yes, the bone is fractured, but success or otherwise is all about the soft tissues. And we know from pretty good human evidence now that either maintaining the soft tissue blood supply to the fracture or recruiting robust blood supply to the fracture has major benefits. When I'm talking about soft tissue blood supply, talking about specifically both the periosteal blood supply, so the blood supply on the surface of the bone, and I apologise for the typo there, also the soft tissue envelope blood supply. So we know that the surrounding soft tissue envelope, the muscle attachments to the bone, are critical for blood supply to healing bone, the extraosseous blood supply of healing bone. So we need to do all we can to maintain or promote a robust blood supply. And these have been shown to reduce infection, produce faster bone healing if we can maintain or promote blood supply, and very interestingly, actually lead to stronger bone healing. And this is really interesting that by maintaining the blood supply, that we can actually get stronger bone healing. And I'll show you some evidence of that. Just briefly, I want to share a couple of slides that Slobodan Tepic very kindly shared with me. And Slobodan, I think, is quite frankly he's a genius, really, and has contributed so much to human and veterinary orthopedics. But this is some of the work from when he was at Davos in the AO Institute. And without really delving right into the details of it, they were in a sheep model. They were looking at the benefit of titanium over stainless steel in terms of plate makeup, and they challenged these sheep with set number of colony-forming units of bacteria, and, if you like, were able to measure the effect. And what they found with titanium compared to stainless steel was that it does have a benefit. We know that. I think most of us recognise that titanium is more resistant to infection than stainless steel, and this had a factor of 10 times protective effect. But the point I really want to make here is that the thing that had the biggest protective effect in this sheep model in terms of infection was maintaining the periosteal blood supply. So they looked specifically, this was in testing of the PC Fix, which was the forerunner of the LCP plate and the forerunner of the ALPS plate. And what they found, that the protective effect of having limited contact on the bone and not damaging the periosteal blood supply had a protective effect of 100 times, so 10 times the benefit of just using titanium. And this is really very important for us to understand. This is again a human paper where they prospectively looked in a trial at using PC Fix, again the forerunner of the LCP and the ALPS plate, and they found a very similar infection rate in managing closed fractures as managing open fractures. And so, in Slobodan's own words, perfusion, perfusion, perfusion. It's all about the blood supply. So perfused bone is resistant to infection, perfused bone heals faster, and perfused bone is stronger. And there's a number of nice experiments. We won't go into all of them. This is a paper that Mark Newman shared with me, and the reference is there. But if I can bring your attention to this chart at the bottom, and this was in a mouse model, and briefly, the control bone is here in the brown colour, and this is the healing where muscle was allowed to be recruited, if you like, to help heal this fracture. This is where muscle was kept from the fracture area, and you can see the tremendous difference that's provided by the effect of blood supply. And this is on load to failure of the healed fracture. This is on mineral density. But I think that we often forget that the biology is the foundation for our biomechanics. So a significant benefit in biomechanical strength of the healed fracture just from the benefit of having a robust blood supply provided by muscle attachment. So plenty of evidence to show that that's important. Okay, so let's have a look at our evidence for bacterial cultures, because this is really very controversial, and the use of antibiotics is also controversial. And I'd say, and I'd put my own hand up to being guilty of it, that I think that we certainly need to lift our game as a profession in terms of how we manage the use of antibiotics in open fractures. And one of the biggest misconceptions from practitioners that I talk to is that open fractures are not infected at the time that we're presented with them. They're contaminated. What we do in the initial few days will determine whether they become infected or not. And a very common question that I get is, if we're treated, when we do case studies looking at open fractures, how would you manage this fracture? A common approach is, well, we first need to resolve the infection before we stabilize the bone. And this is absolutely the wrong way around. This is not the way we should go. We can't resolve the infection effectively if we don't stabilize the bone. And again, instability promotes infection, whereas stability allows early formation of restoration of blood supply, and this in itself is protective of infection. Now, extended prophylactic use of antibiotics in open fractures are certainly not justified. And this comes down to that key point that if we use antibiotics in the initial management of open fractures, we are using them prophylactically. We're not using them therapeutically because there is no infection at the start. If we look at the human evidence, it's reasonably clear that early use of broad spectrum intravenous antibiotics has been shown to reduce the occurrence of infection. But what is still missing, even from the human evidence, is, if you like, the ideal protocol for antibiotic use in these open fracture cases, particularly in regard to the duration of antibiotic use. And there's a number of different papers, and they range from using antibiotics for until 24 hours after the wound is closed. And so that means if it's primary closure, antibiotics used for 24 hours, or if it's delayed primary closure, they're used for 24 hours after that delayed primary closure. And then other papers recommend using for 3 or up to 5 days after the fracture repair, and or after getting a positive culture. So if you are doing an entry or an exit culture, and that culture provides a positive culture, then to use them sensitive antibiotics for somewhere between 3 and 5 days. And our approach here is to use antibiotics for 5 days, really while we're waiting for the bacterial culture to come back. But as you'll see in some of the case examples, some of our historic cases, we have overused antibiotics. So what about, we've talked about bacterial cultures, and this is a very controversial area, and I have to say that the evidence from the human side of things is not clear. And when we look at our small number of cases where we used bacterial cultures, it really didn't particularly help us. And so I don't think there's a clear answer on this. We would nearly always obtain an exit culture as much to make sure that the antibiotics we're using are sensitive, because we have to recognise that all around the world the presence of resistant bacteria are increasing, and in terms of prophylactic use, I'd like to at least make sure that the antibiotic I'm using is effective against the bacteria that's there. But of key importance is that lavage, debridement, and particularly maintaining a soft tissue envelope in an environment of stability is more important than antibiotics. I think we've for too long relied specifically on antibiotics, and that's really not the way to go. In terms of should we be removing the plates that we've put on to treat these fractures, this is similarly very unclear. We explanted 9 of the 33 cases that we treated. All of these cases had healed, and in 8 of the 9 that we explanted, this was elective. And our approach initially was to recommend that in all open fractures where we'd placed internal fixation, we recommended to the owners that they be removed. Now, if you look at the outcome here, we've electively explanted 8 of 9 cases. 4 of those 9 had a positive explant culture despite an original negative exit culture. So what's an exit culture? An exit culture is where performing the original stabilisation surgery, and we're about to close the wound with lavage, that we've placed the plate, and at that time we take a couple of chunks of soft tissue, 2 or 3 pieces of soft tissue that are about 5 millimetres by 5 millimetre diameter, or if there's a bone fragment, we'd submit that, and we would place the swab in that area, and we'd submit it all in one sample, and we do it at the time of essentially closing the wound. The evidence to suggest that an entrance culture, so as soon as you open that surgical wound for repair, is better, is not there. In one of the 9 cases that we expanded, this was a discharging sinus. This was in a 10-year-old cat, and interestingly, we had not performed an exit culture in this particular cat. Let me just show you this cat. So again, at the time of the fracture, this cat was 10 years old, and he had it was a type 2 open fracture, although it's a simple spiral humeral fracture, and it was managed, this is an older case, it was managed with a neutralisation plate and independent lag screws, and this went on to heal well. And this cat had no apparent lameness, and he was a stable diabetic until just under 3 years after the surgical repair. He started to become progressively lame in the operated leg, and the owner didn't do anything about it for a few months until finally a discharging sinus developed over the lateral aspect of the operated humerus. And these 3 radiographs on this side are the radiographs that were obtained at the time of the discharging sinus. And you can see that there's no radiographic evidence of osteomyelitis. There's no change in the implants. There's no lysis around any of the screws. It all looks very quiet, yet there's a discharging sinus there. And so the implants were removed and interestingly cultured in the same way I described. So some of the screws would have been put into culture medium along with some pieces of soft tissue from around the fracture site. And this was a negative culture despite the fact that there's a discharging sinus. And this is one of the problems that we deal with, that it's not always as easy to grow bacteria as perhaps we think it is. I see on the side panel that there's a number of questions coming in, and that's fantastic. I'd really encourage your questions, and I know that Mark Newman is working feverishly to answer some of those questions, and some of the ones he doesn't get through, we'll look at discussing at the end. So that was the only case that we were forced to do an explant in, but most of our clients, once the fracture's healed and the animal has no lameness, they forget or decline the advice to remove. I have to say that most recently, I'm very, very comfortable in not removing implants after open fractures. However, from a medico-legal point of view, we make the owners aware, we put it in writing that there is a possibility of latent infection, cryptic infection. These implants have to have some contamination on them, and we, in writing, advise them of what infection would look like, and if it should become a problem, then we would deal with it at that time. But I think that's important from a medico-legal point of view. Okay, so let's have a look at some of the case studies, and maybe I'll bring the video up here. So this is a young domestic short-haired neutered male cat who got into an argument with a dog, and he's had this really significant crush injury to the tibia. And I have to say that I have the luxury of working with a really phenomenal soft tissue surgeon, Giselle Hosgood, and whenever we're presented with open fractures, this is very much a case of we look at these together, and the soft tissue side of things is very much managed by Professor Hosgood and her team. Okay, so it looks like we have some problems in playing the video, but there's significant wounds over here. You can see the contusion of the distal part of the tibia. These are the open wounds. They're on each side, and there's also some wounds over the abdomen, although they did not penetrate the abdomen. But really quite a significant crush injury. So in this case, this is the planning that's been done. The plan was to place the primary plate on the medial side, and in fact orthogonally plate this, and to place, in this case, a second plate caudally. Now, in most cases, if we're placing orthogonal tibial plates, we would place the second plate, the secondary plate, cranially. But and we recognise that in cats, because they have a less prominent tibial tuberosity, we can get more more proximal with the cranial plate in a cat than with a dog. But the level that we had to get up to with this plate, I felt that this would interfere with the soft tissues. We know that the soft tissue over the stifle joint is very mobile, and so we made the decision to go caudally with this orthogonal plating. And I'm not sure, it looks like we're having some problem with playing the video, but this was an open, but do not. Oh, here we go. Thank you, Calvin. So an open but do not touch, oh, wrong video, never mind. That's another case. We might, we'll just continue on. I don't know if you can still see the main screen, but an open but do not touch approach. And in this case, on opening the fracture, we could find a free piece of, that's the one, a free piece of bone, thank you, that anytime we have a piece of bone that is not connected to soft tissue, then this is an avascular piece of bone, and I would remove it. There's that piece of bone. Thank you for playing the video. So it goes straight into a culture swab, and then we'd also, you can see there, we just take some pieces of soft tissue, and evidence would suggest that 2 or 3 pieces of soft tissue that are representative from within the area placed into the swab are useful. And then, as you saw in the top video, it's a matter of using significant amounts of lavage. A couple of things I'd point out. Waterproof drapes are essential for any implant surgery, and these are waterproof drapes. And when we're using lavage, and no one really knows the ideal amount, but in a fracture like this, I typically put 2 litres through it, just to have some system that we're not flooding the floor. We've just got a kidney dish here. We put the suction into the kidney dish. We've got some sterile laparotomy sponges underneath, just to try and prevent everything from getting soaking wet. But again, I think you can see the extent of the soft tissue damage that's been done by this dog having his this cat's tibia in his mouth. Okay. Thank you for those videos. We'll move on. And so here's the repair. So the primary plate was on the medial side of the bone, and that's a 14-hole, 2.4 millimeter LCP. And again, we need to recognise the importance of having limited contact and maintaining the periosteal blood supply. And then the secondary plate was a 14-hole, 2 millimeter LCP that's been placed caudally in this case. And this is in recognition of the fact that cats have got very long limb segments, so there's long lever arms, and that on the primary plates in the proximal part, we could only get 2 locked screws. And so for those of you that were in a previous webinar on the biomechanics of plating, we'd recognise that without load sharing, 2 lock screws is not sufficient. And with the prolonged healing time, it was important to have some additional stability. So orthogonal plates are a great situation on a tibia. The exit culture that was performed grew nothing, and so 3 to 5 days of antibiotics. In this case, this is the 10-week follow-up, and from the owner's point of view, Jellybean was back to normal. Jellybean was back outside terrorising the dogs. You can see that healing is progressing well. We've got very nice callus formation, and there's no evidence of lysis around any of the implants. And we had talked about the recommendation to remove the implants, but they declined this. And the last time I checked with the owner, Jellybean was progressing well and having no issues. But is it possible that one day Jellybean will develop evidence of osteomyelitis? It is, but the owner's been warned of this. So our second case this is a larger crossbreed dog that 20 hours previously has been kicked by a horse and has this really significant type 2 open fracture. And if you look at the video in this one, you'll see that there's actually no deficit here. And although this wound looks very big, other than the open area, this soft tissue is all viable. It's a partial thickness deficit that's occurred here, but essentially we've got a wound that can be primarily closed. So this deficit is bigger than 1 centimetre. We have comminution in this fracture. So this is why we'd class this fracture as a type 2 open fracture. And as is a very common location for tibial fractures, this is a very distal fracture, and we've got about 19 millimetres of intact bone here in the distal fragment. So again, with this comminution, we know that we're not going to be able to get load sharing. We recognise that even with 2 lock screws, this is not sufficient in a non-load sharing situation, and with the prolonged healing time, we need to do something to reinforce this. So again, this is a really nice indication for orthogonal plating, and you can see that in this case, we've taken advantage of the limited metaphyseal flare on the cranial aspect, and we've placed our primary plate, the 3.5 millimetre plate, on the cranial aspect because it allows us with less reverse contouring and less standoff to achieve 2 lock screws, 2 fixed angle screws without going into the joint. And then our secondary plate, you can see that as you know, the medial aspect of the distal tibia, the malleolus, is much more curved. And we've had to deliberately place a reverse contour on the distal area of the plate to avoid the screws going into the joint. So again, these are fixed angle screws. But with this construct, it's allowed us to get 3.5 lock screws in the distal fragment and plenty of lock screws in the proximal fragment. So again, in this case, exit culture was not performed. I don't know why I did the surgery, and my approach is to perform exit cultures, but I suppose I get older and more stupid. I forget some things. We didn't place a graft despite the fact that we had this open. And I think this is an example here of really irrational use of antibiotics. So I'm responsible for this case, and this case had 10 days of prophylactic antibiotics, which is there is no indication for this, and there's probably really no excuse for that. So this dog was owned by a veterinarian, and we had great follow-up, and this dog was out on the farm doing exercise again in a short space of time, and really did very well. If we look at the walking of the dog, this is 6 months post-op, and the dog's walking quite well. I mean, we haven't put him on a force plate. It's probably, if we force plated him, there'd be slightly less load. But the point I want to make in this bottom video is that the orthogonal plates right down to the hock joint don't interfere with the range of motion. When you're rechecking any fracture, it's really important to palpate the plate and the callus. And this dog is very comfortable, and from the veterinarian owner's point of view, the dog's back running with her and when she's riding the horse, and so is apparently normal. So these are the radiographs at 6 months, and one of the disadvantages with orthogonal plates is that because some idiots put a whole lot of metalwork in here, it's hard to see the fracture, but this is healed nicely. And being a very compliant veterinarian owner, she took our advice to remove the implants, and this is the radiographs following explant. We've got very nice healing of a challenging case. And exit culture again at this point was negative. So anytime we explant, we'd culture and submit some tissue as well. So into our next case, this is an older Maltese Terrier cross that's got these really quite challenging comminuted elbow fractures, and I think this is a case of having a pretty frank discussion with the owner of whether they want this leg and this dog. And you know, Mackie's such a beautiful dog. They definitely wanted Mackie, and they wanted us to try and save the leg. So this is, you can see the extent of the wounds here following the motor vehicle accident, the MVA, and the emergency centre had done a nice job of just debriding this and stabilising him so that he was able to have his definitive surgery the next day. He'd presented in the prior evening to the emergency centre. And so this has been stabilised with in a single stage debride, stabilise and close. So we open those wounds, re-lavage them, redebrided, and then close them. And these are 1.5 millimetre locking adaptation plates, so they're nicely contourable. And you can see that in this case, we haven't even attempted to get compression across the fracture. We've compressed them at the time of surgery and held them in reduction with bone holding forceps. And these plates are acting as much as a tension band as they are a bridge. Again, in this case, no exit culture performed. It's always horrifying when you look back at your cases retrospectively to find that you must have been asleep at the wheel. But again, intravenous antibiotics and again, too long a course of antibiotics. There's no good justification for a 7-day course in this case. Surprisingly, no growth, and that's probably a tribute to the emergency clinicians who dealt with this case overnight. And so here on the right, you can see this is 9-week follow-up, and you can see that we've got quite nice healing of the fracture. Healing is progressing; it's not complete, but there's no lysis or complications with the implants, and the dog's walking reasonably well. This dog, as you would be aware, has to develop osteoarthritis and will never be perfectly normal, but has good pet function and is doing very well. And these implants also were not removed; they're still in Mackie. So our fourth case now is a little bit more challenging. This is a type 3B open fracture. So these are the ones that really cause us really considerable problems. And this video, when it plays, you're looking at the medial aspect of the right tibia, and cranial is to your right. And where the finger is the level of the fracture. So that's the proximal tibia. Where there is viable soft tissue there, you can see that we're just seeing whether this can be primarily closed over the thigh. There's viable tissue, but the entire area over the tibia is not viable. This soft tissue over the tibia is paper thin and not viable. So we've really got quite a problem. We've got a 3B fracture that has a significant soft tissue deficit and is certainly going to cause us some issues. And I think this is a really good case where lots of people say to me, well, this has to be managed with an external fixator. And I think that's not the way to go. This would be more likely to be a complication. So in this case, thank you for playing the videos there, Calvin. So if we come back to the surgery, if you can see on the left-hand screen, we've repaired this with a TPLO plate. The wound's open, the surgical approach is already done for you, so it's just a matter of putting a 2 millimetre locking plate across this. And we debated removing the other implants, but we decided to leave them in place. And that was a very quick surgery, and it's that point that our soft tissue team, Professor Hosgood, came in and did a caudal superficial epigastric flap. And perhaps if we can play that video, I think it's worthwhile that we get a look at this. And again, all of that soft tissue over the medial tibia, where you can see where the flap has been brought down to, was non-viable. So it's been resected, and you can see that this flap extends to just proximal to the hock joint. And what you can see, this is the donor bed. There's a Jackson Pratt drain already in place there to provide closed negative suction when the donor side is closed. But the important thing here is that the whole traumatized area is about to be closed with a robust vascularized soft tissue flap. And if we can move on to the next video, you'll see what it looks like when it's closed. And the key thing I want to come back to is that research we looked at before, that it's all about the soft tissue. And in this case, we are recruiting or bringing in a vascularized, robust piece of soft tissue that is not under tension. You can see these close up very nicely, and you can see here over the medial aspect of the thigh that this soft tissue has been closed without tension. And we think clinically very strongly that this promotes healing, and the research that we shared with you there earlier on would support that. And so here, if we're back on the main presentation, this is what Miranda is like at the end of surgery. You can see the axial pattern flap. Just bring this down here if we can. But the axial pattern flap is really nicely covering the whole traumatized area. We have the donor site nicely closed, and this is a closed suction drain that'll be in place for probably 3 days. So in this case, an exit culture grew an enterococcus that was interestingly inherently resistant to the antibiotics we've been using, and so this enabled us to change antibiotics. But to my horror, when we look back at this dog had 1 month course of prophylactic antibiotics, and again, I would put my hand up and take responsibility for that. That's really inexcusable. It's certainly no justification for it. It's inexcusably long. So again, the point I want to put across is that we should be looking at using prophylactic antibiotics for perhaps 3 to 5 days after surgery, or if we get a positive culture, for 3 to 5 days after that. And so here's the gorgeous Miranda with one of our wonderful nurses, and this is her at 9 weeks. And again, Miranda's a 12-year-old dog, and yes, the fracture's in metaphyseal tibial bone, but it's a severe fracture, and this is her 12-year-old dog 9 weeks post-operatively. And if you look in terms of the cosmesis, she's a long-haired dog, so it's not really an issue. But if you look at where the axial pattern flap has been taken from or placed, it's really very cosmetic. But one of the key points I want to make in this presentation, that we very strongly find that by spending more money up front, if you like, by doing this initial primary single session debride, fix or plate and flap or close, yes, it costs the owners more money initially, but the total cost is less, much less than open wound management. The outcomes are better, the morbidity is lower, and certainly the owners and the animal and our hospital staff are happier with this than the older approaches with the prolonged wound management. So again, those videos are at 9 weeks, and then if we look here at the post-operative, the 9 weeks post-operative imaging, we can see really nice healing. We've got a perpetual non-union. That segmental fracture in the tibia will never unite. The previous cruciate implants are still in place, and we've got really nice healing. And again, this is at 9 weeks in a 12-year-old dog. And why is it healed so quickly? I suppose you could say, oh, well, it's metaphyseal bone. Yes, but it was severely traumatized metaphyseal bone. And if we come back to the mouse research that we looked at previously, the benefit of bringing in vascularized, robust soft tissue to the party, really, I think we need to not underestimate what that contributes. And here is the gorgeous Miranda. She was in seeing our medicine section this is relatively recently, 4 years after her fracture. She still has the plate in. She's still as beautiful as ever. And from the owner's point of view, she's she's never looked back. So she will die with that implant in place. I think beautiful thing. And then our final fracture to deal with, these are the ones I find most challenging, and I hope that some of you out there will be able to make a comment at the end and say, well, I find these, this is the magic solution for these, because I'd have to say to you, I certainly don't have the solution. So this is another horse injury. Horses tend to be bad news for dogs in this part of Australia that I'm in. And Theo had these really quite significant fractures, and he presented to us 24 hours after the injury. He had to be flown in from quite a long way away, and he had open wound management for 3 days because it was not looking like very viable tissue at the time of presentation, and you can see why it's a 3B injury, that there's a large soft tissue deficit, and we have the fractured metatarsals underneath it all. So again, a fracture that you really want to have a discussion with the owners about. Do you want this leg and do you want this dog? And initially, the owners wanted the leg, but declined some of our initial advice. And our advice was to manage this as an open wound and then to go to a pouch flap. And I'll show you an example of a pouch flap in another dog, but I think wrongly they declined this advice initially, and so we set about trying to manage this as an open wound, and this led on to some problems. We had infection, and then after further discussion, day 3 after Theo arrived with us, day 4 after the trauma, he was stabilised with 2 plates and 2 small K wires, and still our owners have declined the pouch flap. And I think in hindsight I should have just said, look, it's either that or it's amputation, but we didn't go that way. And then 10 days after the original presentation to us, this is what the wound looked like, and you can see at this point that this is in for weeks and weeks of open wound management. If we look at this, it's reasonably healthy granulation tissue, but we have exposed bone here, and I think all of you would have treated these. You know how long these are going to take and how much money and time that they're going to take up. So I was very glad to not be involved in the wound management of really any of these cases. And if we can go back to the main presentation. So this is obviously not a Kelpie dog. This is another dog, a working dog that's had a 4-limb pouch flap, but just to try and give you an idea of what a pouch flap is. And I have to say these are very morbid. There's 10 days when the dog is going to be hospitalised with their leg in this bandage, and you have to pick the right dog, and they don't really enjoy it. I don't think we particularly enjoy it, but in terms of a circuit breaker or a way to short circuit prolonged open wound management of these distal limb injuries, we don't have a better way. They're certainly not without their issues, but in this case, it let us get a vascularized soft tissue flap over there. This dog lives about 2,000 kilometres from where we are, and we have limited follow-up. But these are the follow-up images from 10 weeks post-operatively. We do have radiographs that show healing. I said here we don't have follow-up X-rays, but we have subsequently got them. But probably the best follow-up is that this dog is, in this video, is 3 years post-surgery, and he's had no further treatment and no problems, and he's very much back to full function, runs around like a mad thing, and hopefully stays away from horses. So a good outcome of a challenging fracture, but I don't think pouch flaps are necessarily the be all and end all. So really, just to wrap up, these were our main learning objectives that I hope to address in this presentation. And the key points that I really want to emphasize is it's all about the soft tissues. And it's so much about the soft tissues that we need to focus there rather than focus on antibiotics. Antibiotics are not going to save us. Soft tissues and blood supply are what's going to save us. And what I would hope that we've demonstrated to you that early closure with healthy soft tissue that's not under tension speeds healing and reduces infection risk. This is the evidence from human clinical cases. This is the evidence from some of the fracture models, and this is our evidence from a reasonably small case series where we do this routinely. Internal fixation or external fixation, if you love external fixation, that's great, provided that what you put in is going to last the distance of your expected healing time. And unfortunately, we get to revise a number of open fractures that have been wrongly managed with external fixation. Fixation. If you are using internal fixation, we need to look at that work that's come out of the AO Institute that Slobodan Tepic very kindly shared with us, that the benefit of limited contact plates in not impeding periosteal blood supply has a clear benefit on resisting infection. In terms of evidence for emergency operative debridement, there is none that would support you getting out of bed at midnight to come and operate one of these cases. If the animal is stable, physiologically stable, then take the earliest opportunity to stabilise and hopefully primarily close. In terms of antibiotics, the ideal antibiotic protocol does not exist. There's good evidence about the use of intravenous antibiotics, and prophylactically, and I really would emphasise prophylactic use of antibiotics for a short period of time, somewhere between 1 and 5 days, not the 10 days or 1 month that I showed you some case examples of. Exit cultures, should we be using them? I think that we should. I had thought that I did this routinely, but clearly from case examples we don't. My intention is that we would. Why? Because if we identify a multi-resistant bacteria, or at least a bacterium that's resistant to what we've first chosen, then at that point we can revise our antibiotic choice. And I think it's worth it from that point of view. However, can we say that exit cultures are predictive of future infection? Absolutely not. In fact, the opposite would have been true in our case series. Do we need to be strongly recommending implant removal? Originally, 20 years ago, we were recommending implant removal in all these cases. I was quite concerned about them, but as time passes, I'm increasingly comfortable in not removing them, even in the more serious open fractures 2s and 3s. However, from a medical legal point of view, I think that we need to at least advise the owners, give them written advice that it is potential that infection can occur. My email's there at the bottom. I'd love to hear from you if you agree, disagree, if you have any ongoing input, but hopefully we've got time for some questions. Can I again, just before we finish, can I unashamedly try and promote this, what I think is going to be a wonderful symposium, this Bridging the Gap symposium, where quite simply we're trying to connect up some of this brilliant, relevant clinical research from around the world that can directly inform what we do on a daily basis, can directly change what we do. And we want to connect those researchers with all of the people out there who are in clinical practice. So we'd love you to get involved. And again, I can give you more information on that, but hopefully you'll join us. If you have residents or you know of colleagues who are residents and they're doing research,
thank you for that, Mark.
Let them know about
yes,
this.
we have had a bit of an avalanche of questions
any
coming
research
through,
that's relevant,
which is fantastic.
We'd love to.
I was wondering, as you mentioned, there's no real ideal protocol for antibiotic therapy
Mark,
that we have, but do you have any recommendations about the use of local antibiotics, such as PMMA beads impregnated with antibiotics?
Fantastic. I think that it's a good question, Mark. I think that this really reflects what I would say is probably an older idea about the importance of antibiotics in saving our world. And I'd stress here, it's about the soft tissue. It's about the soft tissue. It's about the soft tissue. That's the first thing. The second thing is specifically in terms of managing open fractures, these are contaminated. It's a different argument in managing osteomyelitis, but
likewise, I don't have much
I don't see any
experience or really justification for using high-dose local antibiotics.
And of course, here,
one thing I was wondering about your opinion on is whether your antibiotic protocol changes with the grade of the fracture that you see. So, I might choose different antibiotics if I'm seeing a grade 1 or 2 versus a grade 3B. Unfortunately.
So I suppose for grade 1 and 2, and I know you and I think pretty similarly here, then using a first generation cephalosporin would be our go-to. And in a grade
and what are your feelings on do you have an ideal initial wound management plan that you use? So in terms of dressing choices,
so yes,
how aggressive you are at debridement of those first sort of 24 hours if we're not getting straight into surgery?
Well, this is, I have to say, this is one of the beauties of this combined approach that honestly, I get the radiographs and I look at the wound and I can say to the soft tissue team, okay, away you go. So I'm not the best person to ask, and I know you are more directly involved in that. But what I would say is that if there's no good contraindication to to fixing that fracture and closing that wound, day one after presentation, we'll do it. There's no good reason just to sit on the open wound.
I suppose my choice would be just anything that we can use to debride. If we do have to delay surgery for a day or two, so the saline dressing is probably my choice, or even Manuka honey.
The more likely you are to get
also kind of expanding on from that, I had a question from one of our colleagues in Indonesia who, commonly sees the stray cats that have had an open fracture for several days duration. So we're starting to now deal with the case of, severe soft tissue damage as well as an advanced osteomyelitis. And do you have any separate recommendations for those cases, or are we treating them in much the similar way?
Well, I mean, it's a great question, and those animals are now an infected fracture, an infected open fracture, so they're not a contaminated fracture. In terms of managing them, the principles are absolutely the same, with the only difference being that it's almost impossible to conceive a situation like that where an external fixator will now last the difference, the distance, I should say. So this is going to take, this is tremendously bad biology. It's going to take a long time to heal, and debridement, lavage,
Yeah.
wound cultures, and long-term stability. So bone plating and
Um, and also
and
had
uh,
another
a,
one
a
from one of our
bone
colleagues in
graft,
Australia, and is that, do you think
autogenous
that there's any
cancellous graft,
internal
collectively
fixation that is
separate equipment, etc.,
contraindicated
etc.
in
But
managing open
it's an
fractures?
infected fracture now, not a contaminated open fracture. Yes, lightweight, short-term fixation like intramedullary pins and cerclage wire are not indicated. We know that cerclage wire, there's nothing wrong with it in the right sort of fracture, but um, cerclage wire to be properly applied has to cause the elevation of the soft tissue envelope, not so much damage the periosteal blood supply. But the duration of stability and relying on friction to provide stability and prolonged healing is certainly not indicated. So using iron pin and cerclage is contraindicated. That is internal
Do you have
fixation. I wouldn't
any
use what
problems with
I
using an
and I'm sorry if I
intramedullary
didn't make the
implant
point,
in
but
conjunction with
what
a
I
plate?
mean
So
by
if we're using
internal
a plate rod
fixation is that
construct?
we would use essentially limited contact locking implants in these cases.
Mm.
No, no, I don't have a problem with using an intramedullary implant, and that includes an interlocking nail. And I think that still I hear very commonly in veterinary circles people saying we can't place an intramedullary device because this will spread contamination through the medulla. Well, again, that's a nonsense. We know that in seconds, um, particulate matter that from a medulla is actually in the heart. This has been well and truly shown. So the idea that not using intramedullary devices is protective is patently nonsense. And so I think to use something like a interlocking nail is fine. Augmenting fixation with, we showed two cases where we augmented fixation with orthogonal plates, but plate rod is a great situation. It's about stability and duration. And
And I
in
think
the
your
severe open
point about
fractures, we're using the plates as bridge
the
plates.
introduction of
Slow
bacteria into
healing
the medullary
means
cavity
we
is
increase the risk of
being
fatigue
nonsense is
failure.
kind of,
So we need to
or the effect of that being
increase our
nonsense is
strength
exemplified in the
to
human
increase the
situation where
duration
that
of
standard of
fixation.
care is to use a large intramedullary nail for virtually all open fractures. And I think we are, um, yeah, we're kind of kidding ourselves if we think we have to shy away from putting something in the medullary canal.
Mm. Yeah, absolutely. And one comment, I was talking with Lucas Behra earlier today about open fractures, and he made the point that, and your comment about nailing in people that is typically done minimally invasive made me think about it, that open fractures we can apply and reduce the fractures if you like minimally invasively, but we still have to open the fracture envelope. We have to lavage. So we need to be very
Okay.
clear on that, that there's nothing
And
wrong
there's just one
specifically with a
more, which
minimally
is touching
invasive
on your
approach, but
when
we
you
absolutely
were
have to
bringing
open
talking about
that
the
fracture envelope
titanium
and,
versus
and
stainless
lavage,
steel,
and
the that
in my
beautiful
case,
work
get
from
a
Slobodan
exit
Tepic.
culture off
And
in.
is there any consensus regarding biofilm formation on titanium versus stainless steel? This is from one of our colleagues in Europe, and yeah, do we have a consensus on that?
Mm. Mm. Oh, that's not.
Right.
I
Okay. And I
I
think
don't
that's
think there
probably
is.
about
It's
all we
not an
have
area
time
I
for on the
research
question
in, and
front.
so I think I would be better
Actually, one more has just
to
come in, which I'd
to
like
really
to
pass on the question than give
bring up
opinion.
is
I
just expanding
think
on
we
what we were
need to
talking
try and
about
stick to
before with
evidence.
the
I
potentially
don't
going minimally
research in that
invasive
area.
versus, and also obviously managing the wound. Do you place your implants through the open wounds in some of these cases, or do you always aim for a separate approach to where the open wound is?
I think it's case based. I think probably we would not go through the open wound. Typically, we
Okay,
would
well, I think that's about all we've got time for
excise
from the
the
questions.
open wound as part of the
So,
debridement, and
Mark, thank you very much for that. That was
I
an
think
incredibly
the
enjoyable and
generality would
informative
be that we
talk.
would find a separate
And
approach.
as I say, the question Q&A session was going gangbusters. So it looks like we had some great interaction. Um, Thank you all for tuning in from around the world.
Thanks, Mark, for your input, and we'll try and address any sort of outstanding questions that come in, uh, perhaps
Thank you,
by email
Mark.
or something like that. So, thank you everyone for giving up your time, and keep an eye out for the Bridging the Gap symposium. We'd love